Well, good morning, good afternoon. I'd like to welcome all of you to the seventh in our Mass General series called Answering the Call. These were started just after the onset of the COVID pandemic. And these are designed to address timely topics and provide reliable information for you. Just a few housekeeping issues. First of all, you do not need either video or microphone capabilities to participate in this webinar. And you can ask questions at any time through the Q&A function at the bottom of the screen. And at the end of the formal presentation, we'll get to as many questions as possible. In an effort to get to as many questions as possible, we ask that the questions be as focused as possible. We're reaching the 6-month mark when the MGH actually first sent out its work from home message in mid-March as one of the first things that we did to address the COVID pandemic. And no facet of the MGH has been left unaffected by this pandemic. And today we have a group of panelists that will speak to every facet of that, of what we've experienced, how we're preparing for the future. We'll start out with Dr. Slavin, who will actually be framing the topics that we're talking about from our response to COVID, health equity, to emergency preparedness, as well as the financial impact that this has had on the hospital. And joining Dr. Slavin, we have Jovita Thomas-Williams, who is our Senior Vice President for Human Resources at Mass General. And following Jovita, Sally Mason Boemer, who is the Senior Vice President for Administration, Finance, and the Chief Financial Officer for Mass General. Paul Biddinger, who is our Chief of the Division of Emergency Preparedness and actually Director of the MGH Center for Disaster Medicine within the Emergency Department. Paul, along with Ann Prestopino, have done a remarkable job of clinically leading this institution through the pandemic. And then Dr. Mason Freeman, one of our senior faculty and notable research physicians, is director of the Translational Research Center at MGH, who will be talking about therapies as well as vaccines. So, Peter, I'll turn things over to you.
Thank you very much, Britt, and good afternoon, everyone. And thank you for joining us in this webinar and your continued interest in what's going on at Mass General Hospital. This has obviously been an extraordinary 6-month period during the history of this hospital. There have been some very amazing things that have gone on in the hospital, and also some tragedy we've admitted over 100 patients with COVID-19 who unfortunately have passed away. The mortality rate of patients admitted to our hospital is just a little over 10%, which is much lower than any other number we've heard of. Turning back the clock a few months ago to mid-April 2020, that was really when the Boston area, Massachusetts, hit the peak of its first and hopefully last surge. And we at Mass General had over 350 patients in the hospital, over almost 150 in our ICU, and another 200 in our general care units. And that was quite a time at the hospital, where the water sort of came up pretty far on the seawall, but fortunately didn't breach the seawall. We had ICUs that were converted general care units. We had doctors and nurses, hundreds of them, redeployed across the institution. And both our inpatient and outpatient care had fallen by 50% at the surge, because we wanted to be ready for COVID patients, and also by state regulation, we couldn't do elective activities. I'm pleased to say that the hospital's clinical activities have largely returned to baseline. At this moment in time, we're only caring for a little more than 20 inpatients with COVID. and both our inpatient and outpatient activity have bounced back to almost baseline levels. What's been really remarkable on the outpatient side is how much care we're delivering via telemedicine. At the peak, it was as high, well, a year ago, it was less than 1% of our outpatient activity. At the peak of the surge, it was about 85%, and is now hovering at about 40%. And that's not only true at Mass General, it's throughout the country that telemedicine has really proven so useful in helping care for people during this extraordinary time. As you can imagine, with our clinical activity falling by so much, our finances really took a hit. And you'll be hearing later in this webinar from Sally Mason-Boemer, our CFO, about how that has played out. As you know, Mass General has the largest research program of any hospital in the country, and we certainly activated our research program, or I should say our investigators really sort of rolled up their sleeves and went after COVID-19 with ferocity, the likes of which I've never seen. Both basic or fundamental research and clinical research. And you'll be hearing from Dr. Mason Freeman, who's actively involved in vaccine development, which is obviously a very important part of our research activities. Another thing that happened during this remarkable time was our understanding about how COVID and so many other issues in our society disproportionately affect vulnerable populations. During the surge of COVID, we noticed that 50% of our inpatients with this disease were Spanish-speaking. A year ago, only 15% of our patients in the hospital were Spanish-speaking. So that made us quickly realize that it was the communities of Chelsea, Revere, East Boston that were being so hard hit. At one point in time, we were admitting 15 patients a day from the city of Chelsea alone with stricken by COVID-19. And I'm pleased to say that over the last several weeks, we've admitted a handful of patients from that community with COVID, and we're tracking that on a daily basis. So this pandemic has made us realize just the incredible importance of the social determinants of health. During this period, we were able to clearly see how you could connect the dots all the way from our intensive care units to what was happening in the city of Chelsea, for example. And that's a lesson we will never forget. And you'll be hearing later in this presentation from Jovita Thomas-Williams, our head of HR, about the work that is going on at Mass General and across our system related to health equity. Now we have our fingers crossed that we don't see another surge here in the Boston area, but we also believe that it's better to plan for the worst and hope for the best. So there is a lot of planning going on in anticipation of another surge. How will we redeploy staff? What units will we use, et cetera, et cetera. And you'll be hearing from Dr. Paul Biddinger about those efforts. We received an outpouring of support from people, I'm sure many of whom are on this call, and received, I think, close to 30 million in donations to the hospital to support our research, to support our caregivers, to support all sorts of things that were sorely needed during this period of time. And I just want to thank all of you for standing by this hospital at a time of incredible need. And I'm very proud of, never been prouder of what the people of Mass General accomplished than over the last 6 months. And I hope our services are not called on again in such a dramatic way. But if we have to, we will certainly be there. So I'm going to turn the floor over at this point to Jovita Thomas-Williams, and look forward to participating in the Q&A session. Thank you all so much.
Thank you, Dr. Slavin, and hello, everyone. Good afternoon, and I really appreciate being a part of this webinar today. You've heard from my colleagues previously about the effects of COVID-19 on our hospital community. Unfortunately, there's another pandemic we have lived with for far too long, and that's the pandemic of systemic and structural racism that exists in our country. The events of the past few months have opened our eyes to what has existed for centuries in our country. Black and brown individuals do not have the same access to things that many of us take for granted: education, healthcare, and freedom to live our daily lives. During COVID, we saw firsthand in Chelsea and Revere how communities of color were disproportionately impacted. We all watched in horror as George Floyd's death at the hands of a police officer went viral, and have since seen Jacob Blake and dozens of other Black and brown individuals mistreated by law enforcement. Our employees are listening and paying attention. They are feeling the stresses of society that is dividing us, and they're looking to us as their employer to set an example and step up to end the endless wave of racism in our country. To do that, Mass General Brigham Health System has announced an effort called United Against Racism, of which Dr. Slavin actually is our executive sponsor. Committed to ending systemic and structural racism in our own healthcare system, this group of leaders understand that we only make progress in this fight when our colleagues and patients of color feel fully seen, heard, and appreciated for the value that they bring every day to our hospital communities. Our efforts under United Against Racism initiatives fall into a couple of categories: leadership, employees and culture, patients, and community and infrastructure. Today, I will focus on the first category, and specifically some of the efforts in the area of attracting, hiring, and retaining some of the most impressive talent on the planet. We continued our efforts to hire and retain a workforce that is as diverse as the patients and communities we serve. This is so incredibly important for our hospital and the greater Boston community. Within HR, our talent acquisition team is leading our efforts to find diverse, talented individuals who enrich our hospital community. I want to talk a little bit about this work and how we've continued our efforts despite the pandemic. The team has developed an inclusive hiring checklist to help managers ensure an inclusive environment and welcoming culture within their teams prior to recruitment. All job descriptions are reviewed to ensure that they are inclusive and include the department's and hospital's commitment to our values. We make sure that experience and education requirements listed are actual requirements and not unnecessary barriers to entry. We acknowledge and encourage managers to assemble a hiring team of people who will bring diverse outlooks and are respectful of different backgrounds and experiences. We ensure that all involved in the hiring process understand unconscious bias and how it impacts candidates. Our talent acquisition partners understand that for our workforce to truly reflect the communities we serve, we must hire from the communities we serve. For many years, we have been highly involved in job fairs and local community and four-year colleges that serve primarily underrepresented populations, including Roxbury Community College, Bunker Hill Community College, Ben Franklin Institute, UMass Boston, and North Shore Community College. And with the realization that not all jobs require candidates with college degrees, we also partner with local, state, and national organizations to network, advertise open positions, attend career fairs, and offer readiness resources. Among some of these organizations are the Boston Public Schools, Chelsea Collaborative, Jewish Vocational Services, Mass Hire, Trans Club of New England, Massachusetts Rehabilitation Commission, Urban League of Eastern Massachusetts, Association of Latino Professionals for America, Boston Chapter of the National Black MBA Association, National Society of Black Engineers, Get Connected, Operation ABLE, and many, many more. Of course, hiring is only part of the picture. Once we have our diverse hires here, we need to make sure they feel welcomed, supported, and encouraged to grow. I want to tell you briefly about a few programs that are addressing issues of equity and inclusion among our employees and how we aim to increase retention. Patient Care Services and Human Resources recently began working on a program and a collaborative with Jewish Vocational Services to help diverse employees get the education, financial support, and guidance, and career coaching needed to enter into skilled critical roles. Additionally, we recognize there's a preference of MGH hiring managers in acute care environments to seek certified nursing assistants with prior acute care experience. To better support our own internal workforce and create a wider diverse pipeline, we created an application process where 10 diverse employees receive certified nursing assistant training, career coaching, and test preparation services. These individuals are paired with a mentor, all while maintaining their regular weekly pay. The goal of these 10 participants is to develop skills and competencies that will qualify them for employment at the MGH in a patient care associate role. The aim of this program is to positively impact the choices available to our diverse employees by making education and career growth accessible to them while maintaining their jobs and income. Career development into the role of a PCA is a stepping stone into other clinical options for these employees. By addressing socioeconomic factors like access to education and increased income potential, MGH can do its part to eliminate the barriers of racism. In turn, the result is healthier outcomes for the employee and their families. When more MGH employees and their families have an opportunity to live their healthiest lives, then we as an MGH community will all benefit. This is just a sampling of some of the efforts, but there are much, much more. We are working closely with Dr. Joe Biddinger, our Vice President for Equity and Inclusion, on a number of programs and initiatives to continue to bring change to our organization and create a more equitable culture for our workforce. And here in HR, we have formed a Diversity and Inclusion Advisory Committee made up of employees from departments across the hospital to advise us on how our HR department can better serve our diverse workforce and recruit top talent. I am happy to answer any questions about these or any other programs at MGH. Thank you so much for letting me share a snapshot of some of these programs today. And it is my honor to turn this program over to my colleague, Sally Mason-Boemer, Senior Vice President of Administration and Finance. Sally?
Thank you very much, Jovita, and thank you for having me on today's webinar. I have the opportunity to talk with you a little bit about the financial impact of the COVID crisis, and I'm very happy to be able to report to you today that we are doing well financially, and I thought I'd outline a few of the key reasons and drivers of that performance. When the crisis began, obviously we did what most organizations do in times like this. We tightened those things that were controllable. We tightened up our policies around administrative hiring, use of consultants, and froze any discretionary and capital spending as a way to preserve cash. That was our first tactic. What we saw during COVID was a significant decrease in elective activity. We were perhaps, in retrospect, fortunate compared to some of our other national and regional comparators that we did see a significant amount of COVID care, and we did see reimbursement for that. And I'll come back to that theme in just a moment. So where are we today? Through the month of July, and I think the results will be consistent with my preview of August results as well, but through July, we have an operating margin of roughly $240 million, which is $24 million better than budget. A very surprising result in many ways, and not necessarily consistent with what we've seen throughout Massachusetts, and also as part of the Partners Mass General Brigham system that we are part of. Why is that? Mass General went into the COVID crisis very strong. We were running almost $50 million better than budget and had a strong operating margin, largely driven by volume and acuity, but in addition, driven by the sale of a particular royalty stream, so one-time monetization. Those two things gave us a very strong financial foundation going into the crisis. During the crisis, I can look at the monthly trends of how activity went down, particularly elective, non-emergency activity. In the month of April, for example, revenue was 43% behind budget. May a little better at roughly 30%, and we've been steadily recovering since then. But cumulatively, our revenue went down by almost $270 million during this crisis. We were fortunate, however, to have received federal support to help fill that hole. It didn't fully offset it. It totaled about $200 million compared to the $270 shortfall we saw. Mass General received funding from the federal government in 3 categories. One, all hospitals received funding relative to their size or their Medicare revenue, and we were very fortunate that we got almost $60 million from that. But we received 2 separate payments of what the government called hotspot funding, reimbursement for the amount, and in fact, I'd say the disproportionate amount of COVID care we provided. That totaled roughly $100 million. And then finally, we got some funding for taking care of what they call disproportionate share patients or adverse payer mix, a high government, low income payer mix. Well, that funding, it's questionable whether we will be able to receive it because we are a profitable institution. The way we filed our forms, it showed that we qualified and we received that. So we are cautiously looking out for that one. As I talked about the financial result, it is important to note that we still have a large amount of expenses, particularly for personal protective equipment or PPE at the system level up at MGB, and we are sorting out those. So over time, I expect our supply expense at the hospital will go down and it'll impact our financials, but again, still very strong. Like Peter's commentary at the beginning, I wanted to say a moment about just how fortunate we are to benefit from philanthropy. Mass General brought in about $30 million throughout this crisis for what we call our emergency relief fund. And we're very fortunate to use it in 3 to 4 very key ways. One is supporting our research and innovation mission, where we were pursuing vaccine, clinical trials, and actually even innovative ideas looking at treatments and personal protective equipment. That group really looked at some novel ways to help us. We invested some of those funds very consistent with the comments you heard about from Jovita, really looking at our low-income employees and people who might need some extra assistance during the crisis. We gave out grants to help those employees. We helped some of our high-impacted service lines like pulmonary, infectious disease, et cetera. And finally, our community mission. We did partner with some of our communities, whether it was care kits, food insecurity, important ways we can partner with them during the crisis, and many, many more things from capital and employee support systems. So thank you to all of you on the phone who have been generous donors to us. It really made us a difference and helped us be nimble because while I can tell you now looking back that the financials are okay, at that moment in time, we didn't have the same confidence. That story built, and that flexible funding when we had it was so important. And then my final comment would be looking ahead. We just submitted a balanced budget to our Board of Trustees that we hope they will be approving this week. In times of uncertainty, it's really hard to put together these plans. We don't necessarily want to cut our way out of a problem because we do believe ultimately the volume and the revenue will be restored. So we're working carefully on it. I will say as of now, our trends are we're still running a little bit behind on volume. Fortunately, we are keeping an eye on our acuity, our payer mix, our service mix, which are very powerful financial levers for us and may or may not be able to offset for that lower volume levers. And we are not, unfortunately, expecting any more money from the federal government to bridge those gaps. But we are going to kind of do the prudent, I'll say, operating measures to keep the plan in balance, watch and wait with a careful eye of our workforce who really needs our support right now in case there is a second surge. We have not built that into our budget because if we did and we wanted it to be balanced, we'd have to make further cuts, and that now did not seem the right time when we need to be prepared for whatever the future has in store for us. So hopefully that commentary about that is my transition over to my colleague, Dr. Paul Biddinger. Thank you very much.
Thank you so much, Sally, and thank you to all of you for letting me join you today. It's really a great pleasure to be able to speak to you. As someone who spends his entire professional life planning for disaster, I think even I didn't fully appreciate all the ways in which life obviously has been changed with COVID-19. And although that's certainly a negative in so many ways, even I, as much affection as I have for this hospital and all the people within it, I don't think could have imagined the incredible ways in which so many people have stepped up across this institution to respond. As has been mentioned, we cared for the largest number of patients with COVID-19, both in the floors and in the intensive care units in New England. And then we have extraordinary clinical successes with very, very good outcomes in so many people. But of course, unfortunately, as Dr. Slavin mentioned, tragedy alongside it. The entire institution stepped up. Our nurses, our physicians, our respiratory therapists, but even the research community coming in to help us listen for ventilator alarms when we were most pressed, creating 12 different ICUs outside of our existing ICU spaces. So it's just been an extraordinary time to be part of this hospital, to be part of this response, and I remain so grateful to so many thousands of people across the organization. We have passed our peak, as Dr. Slavin mentioned, in the third week of April, and are what really looks in our data right now like a steady state of COVID in the community. We have, as was mentioned, somewhere between 10 and 20 patients routinely in our hospital, with a small number in our intensive care unit on a baseline basis, and it's really been about like at that level for the last couple of months. We do have an extraordinary healthcare systems engineering team that has helped us throughout this entire pandemic, looking at data modeling, taking a look at all the data from around the world of healthcare system response, looking at our own data. And they've developed an extraordinary model that lets us look about 2 weeks into the future based on what we see in terms of patients presenting to our system and to our emergency departments, our floors, our ICUs. And so far, with that limited crystal ball, we look like we're probably going to be staying at least at that relatively steady state flat level of COVID presentations for the next 2 weeks. As we've looked back over the last several months, really 6 months of incredible response, we are trying our very best to learn all the lessons we possibly can of what worked well and what we need to work harder on. I think because of Dr. Slavin's leadership, investment in emergency preparedness, really good plans across the hospital before COVID-19 ever started, we were in very good position to always make sure we had enough ICU beds, enough ventilators, enough staff to be able to care for patients. But there's also no denying the fact that all of this mobilization of resource has taken a toll on everyone. People are tired and they've been through a lot. We've been debriefing with our nurses, with our respiratory therapists, with our provider groups, physicians, physician assistants, nurse practitioners, and we've been trying to hear from them what their suggestions are for the future, what they would like to see us do differently. So we are coming up with staffing plans that look ahead to the way we would like to deliver care if we see another surge. As you may remember, in March, when we started to see the first surge, the state ordered us to stop all care that was non-essential, and that was true for all hospitals across the state. If there's a second surge, we hope not to have to do that. There are real medical consequences, health consequences to deferring care in the primary care, ambulatory care, procedural inpatient spaces, and we are working with our clinical leaders to figure out how we can preserve access to care for many of our patients while always making sure that we're there to support our communities and those with COVID. We're working both across the Mass General Brigham system as well as with other health systems in the area to try and make sure that the burden of COVID-19 care, the patients that require inpatient care are supported across all of the hospitals, and therefore make sure everyone has access to care. The equity issues that both Dr. Slavin and Jovita referenced are extraordinarily important to us, and we have to make sure that all of our communities can receive the highest possible quality of care, and we're building that into our systems right now. And so now we're really looking forward. We're taking those lessons we hear from our staff, we're taking our data modeling efforts, and we're taking data surveillance activities and putting that all together into plans and procedures to look forward. We look every single day at the communities that we serve at their COVID-19 prevalence rates. We break that down into different groups by race, ethnicity, language. We look at presentations to our ambulatory sites, to our emergency departments, to hospital, to the hospital, to Mass General, to the ICU. And we use that data to try and make sure that we're there, both to be ready as a hospital and support our communities. Mass General continues to work with some of those hard-hit communities that Dr. Slavin mentioned before. We have active outreach programs led by Dr. Jovita that are Spanish language and other language appropriate. We continue to deliver home support kits with masks and sanitizer, educational information, others. And we continue to ask those communities what they need from us to be able to help manage their rates of infection when community prevalence is higher than the average across the Commonwealth. So there's a lot that we've been doing, a lot that we're trying to make sure we can do going forward to continue to deliver the care that Mass General delivers, as well as make sure we're there to support our community in any additional resurgence. I think we are continuing to try and push the message that we're not through this pandemic. Some of you may have seen Dr. Fauci comment about this in the national news recently. We understand that people are tired, they want to get back to normal, and that there's some fatigue with mask wearing, with physical distancing, with some of the most important interventions that have been proved to decrease transmission and save lives. So we're trying to find ways to help message how important that remains. It's not any less important than it has been throughout this entire pandemic. We look ahead to the anticipated flu season, and although we're cautiously optimistic that the data we've seen from the Southern Hemisphere flu season, so their winter, of course, precedes ours and gives us some hint of what a flu season might look like. Their data has been encouraging, showing significantly lower rates of flu transmission. We know we can't bank on that, and so we are robustly encouraging flu vaccination. I would suggest that for all of you. There's never been a more important year than this year to get your flu shot, and we're trying to get that message out to our communities. We're planning for what it means to have a coincident flu and COVID season from the demand on our clinical services, our personal protective equipment, as Sally mentioned, and others. But I can thankfully report to all of you that we're cautiously confident that we're in good shape. Our personal protective equipment stockpiles are good, our plans are good, and we still have incredible engagement of so many people from around the organization. So the last thing we're looking for, but I'll actually use that as my chance to turn this over to Dr. Freeman, is we're looking ahead to the time that we have a vaccine. None of us knows when that would be right now, but we know that from the medical side and from the operational side, there will be significant challenges to make sure that we're able to deliver that fairly, equitably, and quickly to our patients, to our communities, and to our staff. So we're so grateful for the incredible work of people like Dr. Freeman and just the unprecedented pace of research towards vaccine progress. So with that, I'll turn it over to Dr. Freeman, and thank you again for letting me join you.
Thank you, Paul, and good afternoon, everyone. I was asked to tell you a little bit about the status of the vaccine world, both vaccines in development and the current testing of those, when they might be available, and how we actually get from the scientific concept of a vaccine to something that actually can be deployed widely in the country and hopefully enable what Paul just said, which is a prevention therapy that can really put us back, hopefully, on a track to restore both the health of our citizens, our economy, and our healthcare system. To start with, I'll give you a very brief history of the technology of vaccines, just so you get an idea of what's happened in the last year, which has been an extraordinary implementation of recombinant DNA technology and advance in science that occurred over the last 20 years. That's been applied to the vaccine program, which has enabled us to move from the sequencing of the SARS-CoV-2 virus on January 11th, which was released internationally on that date. There was actually the first test vaccine produced within 2 weeks of that sequence. If you think about the history of vaccines, most vaccines take anywhere from 2 to 5 years to produce. the RNA vaccine that was synthesized so rapidly, as I said, happened in a fortnight. So this is just an extraordinary example of technology. That vaccine is now being tested. But if you go back to the origins of vaccines, while they were known actually hundreds of years even before Jenner gets the credit really for starting the vaccine world, he actually just exploited what was known by farmers in the countryside, in the English countryside in particular, which was that milkmaids seemed not to get smallpox. And it was just the acute observations of people, including a farmer named Jesty, who treated his own family with no science, no medicine. He took the material from a cowpox lesion on a cow and inoculated his children, and they did not get smallpox. Jenner systematized that and gets the credit in the history of medicine. But that depended on serendipity. That serendipity was that there was a cow virus called cowpox, actually known as vaccinia, which is where the origin of the word vaccination comes from. And it was that vaccinia virus that was close enough to smallpox virus that by inoculating someone with that, your immune system recognized the cowpox. It doesn't cause significant disease in humans. And that gave you then the protective antibody and cellular immune responses that protected you against smallpox. You jump ahead about 100 years, and it were people like Pasteur, most famously, came up with a rabies vaccine. Now we're talking about bacterial vaccines, because in the 19th century, we couldn't actually culture viruses. So the vaccines that were developed in the 19th century were toward bacteria, which you can grow on a plate without a lot of technology once you realize what the nutrients are. And so those were the vaccines of the 19th century. And then for those of you who are old enough to remember the polio vaccine process of the 1950s, what we did there was a Nobel Prize winning discovery at Children's Hospital in Boston that showed how you could grow a polio virus in a cell culture system. And it was that technological discovery, which won the Nobel Prize, that allowed the polio virus to be grown in cells and culture. And that enabled Salk and Sabin and those that originated the actual vaccines that some of us got back in the late 1950s by being able to grow up the polio virus. What's common to all of these, the idea of a vaccination, is you're educating your immune system to recognize a foreign agent that can cause you harm, a pathogen, a bacteria or a virus, and you present that, some part of that virus or the whole virus or bacteria to your immune system, and you generate an immune response. And that's what we're trying to do. What this latest generation has been doing that I think is extraordinary and very exciting is most of the vaccines I just described required either taking a form of the disease virus and attenuating it or making it weaker, and then that's what you inoculated into someone, and you hoped that you'd weaken the virus enough that it couldn't cause any disease. And of course, back in the 1950s, there was this famous case of the Cutter Laboratories that failed to inactivate the polio virus sufficiently, and about 250 children were actually inoculated with live polio virus, and several of them contracted serious polio disease. So it's always been a goal of medicine and science to get away from using the whole virus, that if it either mutated or it in some way was inadequately inactivated, could actually cause disease, to move into something where there isn't any chance of the inoculating vaccine to actually produce the disease. And that is what the recombinant DNA technology has allowed us to do. Now what we can do is we can grow up a part of the virus that we think is essential to its creating disease, or essential to it being able to divide and replicate, which is viruses have to do inside you in order to produce significant disease. So now we can present a part of that virus to the immune system, not the whole virus, and therefore avoid the dangers of using a whole virus that in some way could actually replicate what the wild type virus does, which is cause COVID in this case. So that's what these new vaccines are doing. There are 4 that have marched pretty much in step. 2 of them are RNA vaccines. One is made by Moderna. Another one is made by a collaboration between Pfizer and a German company called BioNTech. Here, they're simply taking a machine that can synthesize RNA. For those of you who learned some biology in your college years, remember DNA is the gene. You convert that into RNA, which is called the messenger, and then the messenger is translated into a protein, which is actually the functional unit of what you're producing off a gene to actually cause some biological reaction. So the RNA vaccines are just directly synthesizing in the laboratory the protein of the SARS-CoV-2 virus that is required to infect a cell. And now you're injecting that into initially animals and now widely into humans in the study participants in the phase 2 and phase 3 trials. And the goal is to make an antibody to that protein, which is called the spike protein. And the idea is that that antibody will block the SARS-CoV spike protein from being able to bind to largely the pulmonary cells, the lung cells that cause the initial lung infection, and therefore you will be prevented from being infected by the virus. That's the highest bar that we ask of a vaccine, prevention of infection. It's really, really hard to do that. And we will see whether they have succeeded in doing it. A couple of the vaccines have actually published their animal data where they have inoculated monkeys and they have then infected the monkeys with wild-type SARS-CoV virus. This can only be done in a highly regulated, tightly controlled research laboratory because that virus could infect humans. So they're wearing enormous protective gear with all kinds of airflow protections. And 2 of those vaccines have actually shown significant protection of infection, meaning they're keeping the monkeys from being infected. But they also, all of them have been tested so far, have prevented the monkeys from getting seriously ill. And so a vaccine can either stop you from being infected, which would be the greatest vaccine, because then not only do you not get infected, but you can't pass anything on to anyone else because you're not carrying the virus because it's not infecting you. But if it simply mitigates or reduces the amount of disease severity you have, that's also a useful vaccine. And that's what we're in the process of learning about these vaccines today. They're being tested all around the world. The trials that the federal government has mandated through this process that you may have heard of called Warp Speed, where there's a Warp Speed czar down in Washington who's in charge of helping fund the vaccines. All of these vaccines are being tested in trial populations initially estimated at about 30,000 study subjects or 30,000 volunteers. What's really different about testing a vaccine from testing most other new drugs is the only way you know a vaccine's working is you have to have it tested in populations that are still getting infected, because the idea is you're preventing the infection, you're preventing them getting sick. So I can test a diabetes drug and everybody who's diabetic and I measure their blood sugar and I can get an answer in a week. The problem with a vaccine is you've got to go out into a community where there is still an active risk of an infection occurring. You treat most of the people with the active vaccine, but you have to have a group you're not treating with an active vaccine. And you compare the infection prevention in those 2 groups to say, did my vaccine actually work? And that's what's going on now. The Pfizer program has reported that they think they will be done with their phase 3 at the end of September. So it is possible that they will actually have results in time for the November election. I know there's been great skepticism about whether or not that's going to happen. It would be an extraordinary alteration in the protocol for approving drugs to do that, meaning when we submit a new drug now, the FDA takes 9 to 10 months to review it, and that's called the PDUFA date, which is 10 months after you review the information. Here, to have a vaccine by election day, they would have to review, if Pfizer's right and they're done by October 1, they would have to review, look at all the data, say it looks good enough, and approve it by November 3rd. So that in and of itself is just a complete change in the protocol and the way that we review new medicines. Will that happen? Well, you know as well as I do that there is probably some politics that will happen about how the FDA would do that. But all of the manufacturers have vowed not to actually release their vaccine unless they believe the scientific integrity of the data shows that it works. So I think you should have some confidence, but as with everything, trust but verify. We all need to look at the data that's actually presented before we decide whether or not a vaccine is really shown that it works. Vaccines are given to normal, healthy people, typically. So the safety bar for vaccines is very high. They could be terrifically effective at preventing the infections, but if their safety profile means that anybody is injured by them, this is a very difficult trade-off when you're treating people that are otherwise normal and healthy. So the bar for a vaccine safety is very, very high. And historically, for most of the vaccines that you're probably familiar with, upwards of 40, 50,000 people have been tested before a pharmaceutical company has reviewed them. So we are doing things a little differently with COVID, but we've never had a viral infection do what this one has done to our healthcare system and to our economy and killed so many people until you go back to the flu pandemic of 1918. So this is why we're behaving differently. We have worked on one at MGH. We're using an entirely new platform, working with our colleague at Mass Sinai, Luke Vandenberg, using something called AAV, which is not adenovirus. That's one of the lead vaccines that J&J and Astrazeneca are developing. This is new. And while it is somewhat painful to me, we're being slowed by the FDA because they've never approved a vaccine of this kind before. Hopefully those of you on the phone will be reassured that they've slowed us. They are saying, this is really new. We want to make it really safe. So I really do think you can take some comfort in recognizing that the FDA is being very careful about looking at the safety of these vaccines. And I do not believe that they will approve a vaccine that is unsafe. Now, unsafe also means different things to different people. That doesn't mean there isn't going to be a 1 in 10,000 or a 1 in 100,000 side effect that some people are going to have some adverse event with a vaccine, hopefully not a very serious one. But there isn't really any medicine that has absolutely no side effects of any kind in all comers. So you have to take some risk whenever you develop a new medicine. And so it's always hard. One of the questions I was asked to address was, will you take the vaccine when it first comes out? And my answer is, I'm a scientist, I'm a doctor, I will look at the data. And I can't tell you today that I will take a vaccine that is approved on November 1st without first very carefully reviewing what we know about it. And I would recommend to all of you that you do the same thing. I'll end with just the comments. The four, Moderna, Pfizer, J&J, and AstraZeneca all are entering phase 3. We are going to do we hope, 2,000 patient vaccine trial at MGH. I believe it's the largest clinical trial the MGH has ever done on campus. It is an extraordinary effort to staff and find the space. We'll be trying to vaccinate at least 50 people a day for 2 months. Just to give you some perspective on that, the largest trial I've ever done is about 5,000 diabetic patients. We did that in 4 years. So we're doing 2,000 in 60 days. So the pace of this is just mind-boggling. The MGH is stepping up in all the ways I think you would hope it would to try to contribute to this, because I can't think of anything we could do more to help put our nation and our economy and our all of the lives of our citizens on even track, but to help contribute to making a really safe and effective vaccine. So I'll turn that over to Britt. I think he's going to modulate questions to any of us who've been participants. Hopefully I didn't confuse you, and look forward to answering some questions if I can.
Well, Mason, thanks very much. We have a number of great questions. We'll see how many we can get to. The first one, Paul, this is directed to you. The question is, if there is a second surge, do you think we'll be better equipped to handle routine care, given the concerns that you expressed that people avoided routine care during the first surge?
Yes, I absolutely think we will. Again, in the first surge, we weren't given the choice. We were ordered to cease everything that was non-essential. We have good plans in our ambulatory environment, in our procedural areas, and on the inpatient side to preserve access to routine care as much as possible. Clearly, our staff and our space are not infinitely extendable, however. So depending on the size of a second wave that we would see, there would be a toll taken. But we have good plans in place with our clinical leaders in those areas to prioritize which parts of routine access to care we will try our very, very hardest to preserve.
Great. Thanks very much. Peter, this question came in. It said, are there weaknesses that were exposed in the MGH, MGB system over these past 6 months? And if so, which ones would merit immediate attention?
I can't think of three, but I can think of two. So I'll start there and see if any of the other speakers want to add one. I think we, like other hospitals around the country, around the world, bought into this concept of just-in-time inventory in terms of supplies. And I think that, I mean, it's a highly efficient way to manage supplies and inventories, but I think that resulted in us and other provider organizations being caught short in terms of PPE supplies. And as you heard from Paul, we have, as a result of that, built up a very significant inventory of PPE. We now, I believe, have 4 months worth on hand. So I think we learned that lesson from this pandemic, that just in time for certain situations is probably too lean an approach to managing inventory. I guess the other thing we learned had to do with community health. I mean, we pretty quickly recognized the fact that people from Chelsea, Revere, East Boston were getting this disease more frequently than people in more affluent communities. And then we responded. I think if we had to do it all over again, we probably should have responded at an even earlier stage, before people in those communities were getting sick so frequently. So I think prevention rather than just mitigation in low-income communities is something that we need to focus on in the future. And that's why, as you heard from Paul, we are continuing to aggressively work with those communities to make sure that the rates of transmission remain low and there aren't additional surges.
Great. Sally, this one's for you. You mentioned that some of the levers that you pulled initially and turned to trying to address the what was thought to be an impending financial crisis was a holding on capital projects. Will this have an effect on the planning for the new building on Cambridge Street?
Thanks, Britt. That's a tough one, obviously, because we really, ultimately, what we need to do to determine the final timing is really have a better outlook on our cash position, which I don't think we're going to know until this fiscal year and we see about a second surge. I will say what we're doing is try to continue to work in parallel. We have a very long regulatory process to go through anyways, both at the city level in terms of needing an approval, what's called an institutional master plan and project approval, and then through the state. So we are continuing on those regulatory approval steps to try and remain in parallel, and hoping that in the next fiscal year, we'll have a better sense of how to bring that perspective of the regulatory process and real estate process together with the financial position and figure out how we move forward next year.
Great. Mason, one of our attendees has asked, he said, do we have any information about what the issue was with the patient that halted the Astrazeneca trial?
We have a little bit, Brett. Just to clarify for those who may not be familiar, there actually were two serious adverse events in the Astrazeneca trial, which is using an adenovirus analog as the vector for delivering the spike protein of SARS-CoV. So it's a viral vector. It's producing, once it infects the cells of the patient, the vaccine infects the cells of the patient. It produces the spike protein and you make antibodies to it. Two cases have been reported that the AstraZeneca trialists have reported is one case of multiple sclerosis. As of yesterday, at least what I read, they have not disclosed whether that case got the active vaccine or the placebo. So I don't know, perhaps others have seen other information whether they actually got the active vaccine. The other case was a case of transverse myelitis. Transverse myelitis is an inflammation of the spinal cord. It can be mild and it can be severe. In severe, you can range from patients losing motor function, particularly depending on what level of the spine it affects. They could lose the ability to walk, for example, or control their bladder. This patient had a moderately severe case and was discharged from the hospital this weekend, as I understand it. That patient did receive the active vaccine that was announced by the trialist. And so about 1 in a million patients in the country will get transverse myelitis. That could have been serendipitous, or it could be that it was vaccine related. Until you have another case, you have no way of knowing whether that was actually caused by the vaccine or was just serendipity. But it is possible that the vaccine, the virus, in this case the adenovirus, or even the spike protein, set off in an immunologic response. And in that particular patient, that immunologic response led to an attack on the patient's own spinal cord. And this is a very important thing for us to continue to keep a very close observation on. This is why we do large safety studies when we do vaccine trials. And we need to see, is this going to be a recurring adverse event, in which case I think that vaccine will not be widely utilized.
Okay. Thanks very much, Mason. Paul and Jovita, this is one that I think you both will need to handle. A lot of concern has been raised about staff fatigue and stress, and what's being done to address this both for our clinical and our non-clinical staffs. So Jovita, you want to start?
Sure. Yeah, that's been an issue that we have kept top of mind for a very long time. We have stood up a lot of resources for employees, both mental health resources in particular, social work resources, as well as assistance for their families, because a number of the employees have indicated to us that while they are strong enough to handle some of the pressures of caring for COVID patients, which they do every day, their challenge is when they go home and they have to deal with the stress of their families, worried about the possibility of infecting families, what are they doing, and they find themselves in the center of that debate. So we spend an awful lot of time staying very close to the employees and their resource needs. And we stood up a lot of support resources for them that, frankly, if I knew better, I would have done better by having these resources established a long time ago. So now that they're in place, we'll keep them there. But yeah, we're very concerned about the mental health of our employees and making sure that we stay close to them with the resources that we have available.
Yeah, and I would add, I mean, I think Jovita has done an extraordinary job, and she's been since very, very early on in our response, raising questions of how best we can support our employees and providing really, really good solutions. I think there are parts of this pandemic that are just so extraordinarily hard. Jovita hit on one of the biggest ones, which is that worry about your family and your loved ones, along with your worry about doing your job well. And you know, early in the pandemic, when we didn't have nearly the data that we now have about the effectiveness of our personal protective equipment and the safety of the work environment, those questions I think were harder to answer because the data just didn't exist yet. Now we have confidence, but people still have those fears. I think, you know, the pandemic still keeps us isolated from one another. And, you know, in other times, people would be going over to each other's houses or going out for a beer. And they really can't do that the same way. And so I think it really underscores why we need to continue to think of creative solutions. I know that, you know, Jovita and her work and so many, we're trying to make our managers aware. We're trying to keep an eye out for those employees that might be struggling. We're trying to create support groups so people can at least talk to each other virtually. But as Jovita said, I think this is going to be a struggle for a very long time, and we're going to need to keep these resources active.
Great. Not surprisingly, you know, given the attendees that we have a number of other great questions, which unfortunately we're not going to be able to get to, but we will provide answers that you'll have access to online. And Peter, I'm going to turn things over to you to see if you have any final closing comments you'd like to make.
I just want to thank my four colleagues for their terrific remarks. Jovita, Sally, Paul, Mason, thank you for participating in this forum and for the incredible work you do every day in our fight against COVID. Britt, thanks to you and the Development Office for helping raise the resources we need to have a maximal impact here. Performance of the entire hospital, including the Development Office during this period, has been extraordinary. And last but not least, I just want to thank those who participated in this webinar. We couldn't do what we do as a hospital without the interest, support of our patients and others in the community. And so we are just so grateful to you for joining this session and being there for us when we need it. And we will certainly do everything we can to be there for you, your families, and community you live in as well. So thank you so much.